Candace Black is a research scientist with a research program on children and adversity in the Boston College School of Social Work. Dr. Black's research interests explore whether biological aging processes can be leveraged to improve health across the lifespan, particularly in trauma-affected children and adolescents. Dr. Black oversees the scientific execution of longitudinal study of war-affected youth in Sierra Leone to understand the social and biological mechanisms underpinning international impacts of war. She also conducts implementation science research to support scaling of interventions serving conflict-affected families. Prior to joining the investigating biological embedding of, I'm so sorry, I lost my train. Prior to joining her current location, Dr. Black was a 2021-2023 Marie Curie Fellow investigating biological embedding of traumatic experiences in Syrian refugee children, and in 2019-2020, Maternal and Child Health Fellow of the Arizona Leadership Education in Neurodevelopmental Disabilities Program. So we are very lucky to have her, and we are excited to hear about her very interesting methodology in addition to the very important content. Thank you so much for being here. I'm going to hand this over, and as Russ mentioned, the chat is open. We are going to take your questions in the chat. If it's clarifying question, we are going to stop Dr. Black and ask those immediately. But if they are bigger picture, please do put them in and we will wait to the end and we will help facilitate this discussion. Thank you so much, and let me hand this over.
Thank you, everybody. It's a real honor and pleasure to be here sharing this work with you. I'll be talking about our hybrid type 2 implementation effectiveness trial in Rwanda. Briefly, to give you a presentation overview, I'll describe the Sugira program, which is Strengthen the Family in Kenya, Rwanda. And I will also describe our scale-out strategy, which is called the Play Collaborative. And I will describe some of the results of both the embedded effectiveness trial as well as the implementation outcomes. And then we'll discuss. So this work would not be possible without the teams at Boston College. Obviously, this work is led by Dr. Teresa Betancourt at Boston College and our partners at the University of Rwanda, as well as FXB Rwanda and our field team. So big thanks to them for making this work possible. So briefly, to introduce you to the context in which we are delivering this intervention, Rwanda has a history of compound adversity. They experienced a 4-year civil war, which ended in the 1994 genocide of the Tutsi, where nearly 1 million Tutsi were killed. Today, there are approximately 13.5 million inhabitants, over half of which are under 20. They are making good progress in addressing infant and child mortality. Under 5 mortality has declined about 5.5% from 2022, with greater decreases in the longer term. But they still face challenges, particularly reaching families in rural areas and high levels of poverty still nationwide. With that said, there are a lot of political strengths in Rwanda. They have political stability as well as strong political will to address things like poverty reduction, and also they also value the role of early child development in the promotion of human capital development for their longer term goals of achieving status as a middle income country. The family-based Sugira again, which is strengthening the family, is a family-based intervention designed to prevent violence and improve parenting behavior to support early child development. This was developed in partnership with government in Rwanda. We've had long-standing partnerships with key stakeholders in Rwanda, including government as well as others, that helped shape this intervention. It focuses, it is a home visiting intervention, and that's really essential for being able to bring in multiple caregivers into the intervention. So it allows us to deliver the intervention to fathers and other extended family that are also involved in caregiving. The content is informed by the Nurturing Care Framework. So it includes sort of standard content on stimulation, nutrition, and hygiene. But also, because of the history of communal violence, has significant content on problem solving, conflict resolution, alternatives to harsh discipline, stress management, and other things, other topics to help address the risk of family violence in this particular population. It is flexible for all family types, including both dual and single caregiver households, as well as teen mothers, with, again, a strong male caregiver engagement component that is facilitated not only by the home visiting, but also the flexibility there, but also helps us really address family violence. This program is meant to be complementary to alternative delivery platforms like ECD centers, whereas those ECD centers are better suited for families living in more more urban areas. Something like Sugihara Muryango is really designed to address the needs of families in more rural settings. And then per all of our intervention work, we really focus on strengths-focused and resilience and capabilities, not just deficits. So briefly, to give you a little bit of history of Sugihara Muryango, it emerged out of family-based research for families affected by HIV. Essentially in 2011 and 2012, that work was emerging. Over time, the priorities of the government and funders, both government and funders, sort of shifted. And so this family-based intervention was adapted to really meet the needs of families with very young children under 3 years. And it has been pilot tested twice, as well as tested in a cluster randomized trial, and included in an expansion study, which is the main thing that I'll be talking about today. So just to demonstrate effectiveness of Sugihara Muryango in our cluster randomized trial, we found that immediately following the intervention, we observed greater provision of stimulating care. That's things like reading, singing, playing with the children. Caregivers provided more learning materials in the home, and also increased appropriate care seeking for child health symptoms like diarrhea and fever. They also increased hygiene practices around the home, such as safe treatment of drinking water. Violent child discipline decreased, as well as intimate partner violence, and both mothers and fathers showed decreasing depression and anxiety symptoms, and increased male engagement. 12 months later, which is when we really expect that the parenting behaviors that we're promoting in the intervention, sustained over time, will then impact child development. At 12-month follow-up, we saw improved children's development with regard to motor skills, communication, problem solving, and personal social skills. And the reductions in family violence continue to be reduced at 1 year later, as well as increased male engagement. Now, how do we sustain that impact in quality when scaling out and using a government workforce? Now I can introduce the Play Collaborative, which is the Sugihara Muryango expansion program implemented by Boston College, the University of Rwanda, and FXB Rwanda, with generous support from a number of funders and support from our government partners. The Play Collaborative was designed to reach 10,000 families while testing an implementation strategy that involved multi-level stakeholder engagement as well as quality improvement. So in this case, we shifted to a new workforce called the Inshuti Zumuryango, or IZU, as I will refer to them later. They are essentially a cadre of child protection volunteers that are recruited from within the villages to engage in child protection activities through home visits, and basically identification and prevention of child abuse and neglect, addressing family conflict, and providing supports and referrals where necessary. And so essentially through an MOU with the Rwanda National Child Development Agency, we then delivered Sugimuryango with the ISUs. In this case, the Play Collaborative is based on interagency collaborative teams. Greg Ahrens has written about interagency collaborative teams, essentially bringing in stakeholders from across the ecosystem to engage in and coordinate the scaling and delivery of the intervention. Within the larger implementation, we also included an embedded quasi-experimental effectiveness trial that examined whether Sugimuryango effectiveness was maintained when scaled with this new workforce, as well as with expanded age eligibility criteria. The previous cluster randomized trial included families with children 6 to 36 months, whereas the expansion included families with children from 0 to 36 months. So we have younger children in this sample. And then we are on an ongoing basis developing a locally hosted digital dashboard to help support quality monitoring and real-time feedback and quality improvement. So the Play Collaborative was informed by the EPIS framework, which I'm sure as many of you know is the Exploration, Preparation, Implementation, and Sustainment framework, and essentially was designed to support transitioning delivery of Sugimuryango to the government of Rwanda. And that is in collaboration with the strong network of government and local stakeholders. And these include various ministries, the National Child Development Agency, the ISUs, as well as civil society organizations. We focused on training, delivery, and supervision by a cross-site seed team and cell mentors, which is essentially establishing a lasting hub for training and supervision. The buy-in was encouraged by a shared charter that all partners of the Play Collaborative signed, that involved a mission to commit to problem solving and overcoming implementation barriers. Quality improvement cycles such as Plan, Do, Study, Act were baked into the process, and we offered continuous training opportunities to create a community of practice. So in these, in the Play Collaborative, we had meetings that again created that community of practice to reinforce knowledge sharing, problem solving, overcoming implementation barriers, and to enhance buy-in and shift ownership to government. The meetings were held to problem solve challenges raised from the community, Sugimuryango volunteers or staff and government officials, challenges that are not resolved or need support or resources within a level then can be transferred to the next level up. So for example, a problem that needs more support on the cell level will be transferred to the sector meeting for additional support. Our embedded effectiveness study used a waitlist control design. We stratified the sectors within district based on geographic characteristics, as well as the number of alternative programs offering similar content. Full randomization at the cluster level was not possible because of government concerns about reach, but we did try to avoid misbalance. We statistically matched treatment and control sector, or excuse me, treatment and waitlist control sectors. And then randomly selected within each of those to identify villages and households. So ultimately, the total sample size included 184 villages with 538 households, 778 caregivers, and 555 children. Our data were collected at baseline, our quantitative effectiveness data were collected at baseline, post-intervention, and 12 months after the intervention. And then our implementation outcomes were measured immediately post-intervention. We did have some qualitative work that was done as well. I won't be presenting that today, though. So when we look at our embedded trial descriptives for the children in this sample, the average age of the child participants was 13.3 months. And this represents the inclusion of a sample of 106 very young children, aged 0 to 6, in line with our expanded eligibility criteria. In contrast, the CRT participants had with eligibility of children 6 to 36 months had an average age of children of 22 months at enrollment. As you can see, the education level of caregivers was really quite low, with most having primary education or less, and a significant minority reporting that they are unable to read or write. With the data collection instruments, we collected direct child assessments of child development, as well as caregiver report on children. This included the mix multi-indicator cluster surveys, 5 early child development module, the child discipline module, WASH indicators, which are water, sanitation, and hygiene indicators, and then 24-hour dietary recall. We also looked at observation of mother-child interactions, home observations for the measurement of the environment and ages and stages. Among caregivers, we looked at demographic and health survey items, shared decision-making, father engagement, Hopkins symptom checklist, difficulties in emotion regulation. IPV was measured with the DHS items. And then our implementation measures included typical D&I measures like adoption, feasibility, appropriateness, and one that's going to escape me at the moment, but we'll get to it. And then also we looked at things like within the Play Collaborative, like organizational climate, leadership, sustainability, and perceptions of the SEED team. So when we looked at our results for the effectiveness trial, immediately when looking at the home environment, immediately following the intervention, we did see significant improvements with respect to home environments overall. And this appeared to be driven by improvements in the provision of learning materials, as well as how much caregivers involved children in their daily activities. At 1 year follow-up, we did see the maintained increased involvement of children in daily activities. However, the rest of those effects were not significant at the 0.05 level. They were marginally significant. And depending on your perspective, you don't talk about those at all, or you just mention them briefly. So we had trends in the overall improvement of home environments and trends in increased learning materials, but again, not statistically significant. However, with respect to the early stimulation measure, we saw that both immediately following the intervention, we saw significant improvements immediately following as well. That effect was even stronger at 1-year follow-up, so that was really nice to see. With respect to father engagement, we saw high participation of male caregivers in sessions. Median engagement was 11 out of the 12 sessions. Immediately following the intervention, we observed significantly increased father engagement in caregiving activities. And then at 1-year follow-up, that particular measure was no longer significant, and we saw something counter to our expectation, that we saw a reduction in father involvement about decisions about what the children were eating. However, we think that one possibility for this finding is that male caregivers may have been out of the home more at follow-up. So keeping in mind that this program was delivered, baseline data collection was May 2021, immediate follow-up was end of 2021, so October, November, and then 12-month follow-up was end of 2022. And so this is occurring right around the height of the COVID pandemic. By the end of 2022, it may have been that, at that time, more than 2/3 of the population had been vaccinated. The number of new COVID cases was near zero. We did find that families reported significant losses of income. About 2/3 of the families in our sample reported loss of income, and 75% reported inability to afford food at baseline. So we think that it's possible that, by follow-up, it might be that fathers were leaving the home to generate income as the restrictions loosened. Obviously, that is speculation. With respect to the observation of mother-child interactions, we didn't observe any significant intervention effects. And this is in contrast with our previous cluster randomized trial. But we think this may be due to the younger age in this study. As I mentioned, the eligibility criteria shifted to include younger children. But the OMCI was developed for use with children 12 months and older, which at baseline would have included only 58-ish% of our sample. So it, this highlighted a need for us to find similar measures that are appropriate for use with children under a year of age. With respect to family violence, in contrast to our cluster randomized trial, we did not observe any effect of Sugir Muyongo on intimate partner violence at baseline, at immediately following the intervention or at 1-year follow-up. This was sort of surprising considering, but upon reflection, we think there are a number of things that can explain this. First of all, we shifted measures. We had good intentions. As expansion was implemented with government partners, we had received feedback that where possible, we should use measures that align with those collected as part of nationally representative surveys, like the Demographic and Health Survey. So we did update our IPV measure to reflect this and to honor this request. However, that population level survey uses a different reference window than the one we used in the cluster randomized trial. The cluster randomized trial used the conflict tactic scales and had used a reference window of 3 months, which aligns roughly with the delivery period of the intervention. But the Demographic and Health Survey's IPV measure refers to the past 12 months. And so it may be that we've lost some sensitivity as a result of this 12-month window, especially because the measurement from baseline to follow-up is roughly 6 months. And so, it's possible that we just lost some sensitivity there. So the other thing that we have to consider is the potential impact of COVID. As I mentioned, the trial was conducted at the height of the pandemic. And so what the initial data collection points were prior to the distribution of vaccines that could mitigate impact, as well as, quarantine restrictions and whatnot. So the pandemic was known like almost immediately following the closures, the mass closures. There were reports worldwide of potential risk to elevated family violence as a result of stay-at-home orders and, families not having alternative options to manage stress by leaving the home, as well as elevated stress due to the losses of income and other aspects that COVID really affected with respect to these families. So we think that, that this could have contributed as well. And then last, we also think that delivery by EZUs could have played a role. On the one hand, the remit of the EZU program is to identify and intervene in cases of child abuse and neglect and counsel families in conflict. So in other words, the families in the waitlist control could be benefiting from that EZU engagement, as well as effective support to reduce family conflict and violence. And that would eventually attenuate the intervention impacts on certain measures like intimate partner violence. So I think that, there are a number of factors that have contributed to our lack of finding. With that said, of course, we're doing a lot more work to review not only the curriculum, but also the training and supervision materials to sort of look at what might be going on there, where we can strengthen impact. With respect to harsh child discipline, we did see significant reductions in deprivation-based harsh discipline immediately following the intervention, but no effect at one-year follow-up. And we do think that this outcome also could have been impacted by conditions associated with COVID, including the stay-at-home orders and household stress. But also the younger age in expansion may have played a role. In Rwanda, we have evidence that the risk of violent discipline increases with age. And so in the current study, baseline prevalence of harsh discipline was about 34%. But in the cluster randomized trial with the older children, the baseline prevalence was about 46%. So the younger age range may have also decreased the magnitude of effect that Sugiyama could be expected to achieve. And then again, delivery by EZUs may have also played a role given that given the potentially attenuating effects of having a waitlist control condition that is also receiving violence reduction. With respect to hygiene and feeding practices immediately following the intervention, as well as one-year follow-up, we saw significant improvements in safe water storage and treatment. Immediately following the intervention, we saw a trend toward improved use of soap to wash hands. With respect to feeding practices, we saw significant increases in dietary diversity immediately following the intervention, but not at one-year follow-up. With that said, we're still impressed that we observed an improvement at all, given the significant difficulties reported by these families, with more than 75% indicating they could not afford enough food to eat at baseline. With respect to children's health and development, immediately following, so this is a measure that looks at children's health symptoms in terms of diarrhea, fever, and cough, and then asks caregivers if they sought care for those symptoms. And so essentially we look at the symptoms and then the care seeking. So immediately following the intervention, we saw no effect on health symptoms. We did see a trend toward increased care seeking for diarrhea symptoms, but it was not significant. And at 1-year follow-up, in contrast to our expectations, we saw significant increases in reports of fever and cough. Again, with that said, we think that this reflects in part the COVID pandemic. The child illnesses we were looking at, the symptoms we were looking at corresponded with COVID symptoms in babies and children. And it's likely that caregivers were particularly monitoring these symptoms, especially for Sugiyama families, since the They receive supplementary coaching and support on COVID-19 symptoms, safety and hygiene, so it may have been just more salient to them. Moreover, care seeking could have been impeded by fewer healthcare services as a result of the pandemic. Child development. Unfortunately, we didn't see any effect at 1-year follow-up for child development. Now, I should clarify that according to our theory of change, we expect Sugir Muyanga will significantly improve caregiver behaviors immediately following the intervention. And then with the improved caregiver behaviors in things like play and stimulations, improved diet and improved care for health symptoms and reductions in family violence, that in the long term, this will ultimately result in improved child development. And in fact, that's what we saw in the cluster randomized trial. But for expansion, this is not what we saw. We didn't see the same magnitude of effect. We saw a trend toward improved problem-solving skills. So that was disappointing for everybody all around. And so we have a lot to do with regard to trying to understand why these particular outcomes may have not persisted in the context of scaling. There are a number of factors that could have played a role, including the maybe weaker effects on parenting behavior, but also one of our funders, Lego, has a external partner who conducts a outside evaluation called FHI 360. And their external evaluation had indicated that EZUs may spend less time reinforcing concepts less closely linked to their remit, as well as less effort on concepts that they feel lacks a tangible benefit from their perspective. And because child development requires sustained improvements over a longer time horizon and less visible benefit as compared to some of our other outcomes, we may need additional training for the ESUs and their supervisors as to the importance of improving child development along with the activities that promote it. So we are working on reflecting those findings in our curriculum. With respect to anxiety and depression, we found that caregivers who receive Sugir Muyanga experience fewer mental health symptoms overall, with mainly driven by decreases in depression symptoms and trend toward reduction in anxiety symptoms. However, these findings were no longer significant at follow-up, and we also did not observe impact on a screening indicator based on the same measure that indicates, flags participants for high internalizing symptoms. However, these results may make sense in the context of delivery. During the intervention, they're receiving regular home visits that involve social support, encouragement, active coaching to improve communication, problem solving, and self-care skills. EZUs are trained to establish and maintain trust, coaching caregivers, avoid shaming, judgment, and bias, and use active listening and problem solving skills to support family functioning. Altogether, these experiences are probably contributing to the reduction of depression and anxiety. Once the intervention ends, however, these supports also become less frequent, and that might contribute to the lack of follow-up at 12 months. With respect to implementation outcomes, during the first phase, we trained 2,608 EZUs to deliver Sugir Muyanga to 8,529 families. Each EZU met approximately with 3 to 4 households. 92% of EZUs stayed on for the entire implementation schedule. And so we just had great participation and retention. Let's see, through the Play Collaborative, we trained 6,285 local officials and engaged 15,351 government officials in over 2,800 Play Collaborative meetings. At the cell, sector, and district levels, these meetings were frequent and regular for EZUs and their supervisors. At the cell level, EZUs were meeting on average 1.2 times per week throughout the course of Sugir Muriango delivery at the sector level. Supervisors and cell mentors met on average once every 2 weeks. Although pandemic-related restrictions forced Play Collaborative members to reduce the frequency of in-person meetings, they still maintained this frequency through other channels. And so just incredible participation. When we looked at the dissemination and implementation outcomes, acceptability, that was probably the one I missed. Okay, so we saw that across these measures, Play Collaborative members, caregivers, and ESUs rated feasibility, adoption, acceptability, and appropriateness quite highly, with 4 being the top response there. Where ESUs were reporting or rating organizational climate and general leadership, as well as implementation leadership of their own, as well as reporting on their supervisors. Again, very high reports for these groups. With respect to sustainability, that particular measure ranged from 1 to 7. And we saw, again, high levels, high perceptions across these subscales, with the lowest on environment, which included things like, I believe, funding landscape and things like that, which makes sense, is with the C team questionnaire, with 5 being the most favorable response. You see, again, extremely positive perceptions of the C team. And with respect to fidelity and competence of the ESUs delivering the intervention, they significantly improved their fidelity and competence over time. There was high supervision, so cell mentors aimed to supervise half of the modules, and about 5% of ESUs were supervised for 5 or 6 modules. Nearly 70% were supervised for 6, and 10 were supervised for 7. And with routine supervision and time, these scores improved over time. So we were very pleased to see that. With regard to the next steps, we are working on a route to expansion. Obviously, the changes to the U.S. funding landscape, things like USAID, has been a bit of a barrier in our plans, but we're finding alternative pathways to expand the workforce and expand it to other districts, is what I'm trying to say. We've received good support. We've received MOUs from the National Child Development Agency and other ministries that commit to continuing to scale Sugir Muriango and achieve nationwide scaling. And we are working on a digital dashboard. We're really advancing that work through a US NIH R01 to improve the digital dashboard, to support real-time monitoring and ensure quality delivery and sustainment. And of course, we're working on sustainable financing in spite of the situation in the US. We continue to maintain strong government engagement with our partners. This was our regional symposium in Kigali in 2023. And so in summary, the Play Collaborative was able to successfully scale and deliver Sugir Muriango to nearly 10,000 households, successfully promoting early child development for hard-to-reach families, using a community-based implementation strategy to engage local stakeholders and to structurally support and sustain Sugir Muriango. We found that Sugir Muriango maintained effectiveness across many of our outcomes. For those that were not maintained, we are exploring reasons why that might be the case, and also conducting reviews of our curriculum and training materials to ensure that that we strengthen those areas. We think that the implementation data tell us that beneficiaries were highly satisfied and perceived both Sugir Muryango and the Play Collaborative as adoptable, acceptable, and appropriate. And we have good reason to think that they also think that this is scalable and sustainable. I would like to thank and give acknowledgments to all of the people that have made this possible and leave a little bit of time for questions, I hope. Thank you so much.
This was fantastic, Dr. Black. Candace, thank you so much. So many components, such rich data collection. I don't know how to do that in real life. So thank you for sharing that with us and some amazing results. I was especially impressed by your focus on sustainment and thinking about it in a multi-level way and multiple strategies.
Yes.
I have a lot of excitement and questions, but I would like to actually open it up to the audience first to bring in some of the questions from the audience, and then I'm happy to be the last one. So please, everyone, come off of mute and come on camera if you have a specific question. Jackie, I don't know if you would feel comfortable asking your question live,
Yeah,
but
sure.
something in the chat. Yeah.
Yeah, I'm just super, super impressed by all the work you're doing and incredible engagement just throughout from the beginning. I think you said only 1% did not participate. And then just the follow-up and also engaging everyone at all the different levels. I'm just wondering what you did to make this successful. I would love to learn from it.
Yeah, well, it definitely wasn't me. It was all of the incredible work of our partners. We have okay, I should say that, Teresa Betancourt, who leads this work, she is she has very strong commitments to the folks that she works with. So she's worked in Rwanda for over 15 years now and has established strong partnerships there. And I think that makes a massive difference. I think there's such a need globally for work like this. And there's countless opportunities to, bring it to other places and to other communities and things like that. And while that I know is a long-term goal, from Teresa's perspective, she really commits to a place. So she has committed strongly to Rwanda, strongly to Sierra Leone, and strongly to the US refugee population. And I think that makes a huge difference. 15 years of partnerships and making inroads with government and all of that makes a massive impact on one's ability to do this kind of work. And so, we also have incredible folks. What our program manager, Gabby Fend, she's a miracle worker. She's so good about engaging our key stakeholders from across the ecosystem. And she just is really remarkable at how great she is about establishing those relationships. So really, I do think a lot of it has to do with relationship and relationship building that is able to support this kind of work. Did I answer all of your question?
Yes, thank you.
Thank you so much, and great question as well. Russ, you had a number of questions. Would you like to bring in one of them, and then please others as well use the chat or prepare to ask questions live?
Sure. You're right. I do have many, but first of all, let me just say how impressive this is, the comprehensiveness of what you've done. Not only the scope, but the just the measurement is just phenomenal. And as was commented on, the ability to collect the data there from multiple perspectives was really, really great. I'm just intrigued at your experience and would love to hear kind of your lessons learned about engaging the government agencies. I think that's somewhat unique for the work that we do at the levels you have and just lessons learned there. And then semi-related to that, I can't help but note the slide that's still up there on your funders. And I'd be interested just to understand a little bit more about that and that environment. Of course, I can't help but seeing USAID there, kind of fairly prominent. And just, I don't know, any reflections that you might have on that and how you work both with the government and the funders, I guess, to kind of wrap that up.
Yeah, I mean, and I think, the way that the Play Collaborative was structured really supported that regular ongoing engagement with government partners. And it also was really good at establishing the structural and procedural supports necessary for scaling. And so we had, this very regular interaction with government partners at all levels of the administration in Rwanda, which includes, national, district, sector, cell, village, etc. And so we were engaging at all of those levels, but then also really supporting this cross-site learning across, because we were in 3 different districts and they weren't next to each other, so the Play Collaborative really supported cross-site learning. So if folks in Rubavu district were struggling with a particular problem, you could bring it to these meetings, and it would enable this cross-site learning and problem solving to overcome those implementation barriers. And I think that ongoing regular engagement and interaction, has really played a massive role in how supportive the ministries are, and how supportive the National Child Development Agency is. They're very excited and enthusiastic about this work and scaling. With respect to the partners, the funders, in this case, expansion was funded actually by a lot of foundations, as opposed to, a lot of our work is funded by NIHR1s and things like that. In this case, it was not. And so, these, I don't know if you have a specific question, but these funders specifically addressed different aspects. And actually, I might have in my, hold on, did I save it in my slides? Let's see. No, I didn't. Oh, well, that's okay. I have a slide on this, actually. But basically they had specific interests that they wanted to fund. So for example, Echidna was really focused on the gender transformative aspects of our work. Lego was really interested in promoting the play aspects of our work. And so they all were invested in particular components that really enabled the work. USAID was originally going to help us scale to a new district. Obviously, they are not now, but incidentally, our great partnerships with Grand Challenges Canada has meant that they then stepped into that void and are now going to cover that work. So it's really relational. So it's a lot of good relational work that's been done. But
yeah. Thank you. That's again impressive. I'm guessing some of the answers to both of those questions reflect maybe the 15-year experience and commitment of Dr. Betancourt to be able to pull that off. Can I ask, was there like one primary funder in terms of the amount of contribution, or is it just that was impressive, and also how you're able to integrate all those, I'm guessing, diverse interests and foci?
Definitely. So I actually probably couldn't tell you. I would have to ask. So I can't tell you actually who the main funder was. If I had to guess, I would say probably USAID was doing a big chunk of it. And then the others were doing sort of smaller parts, but everybody really came together to make this happen. So nobody was, everybody was contributing significantly. I'll just leave it at that.
Thank you.
Yeah.
I see a message from Kristen. Kristen, would you like to state this yourself?
Sure. Thanks so much for the chance to ask a question. Yeah, just to reiterate what everyone else is saying, it's such an amazing work and looking at implementation at the same time as effectiveness. I guess my main question here is, you know, the FIM, the AIM, and the IAM we were developed in the US, and I've had issues with trying to use them, especially in LMIC settings or with non-English speakers in the US. And I tend to get like maxed out, like everyone's giving everything a 4. And then you do qual interviews, and it takes a while because people, I think, tend to have a bias towards not disclosing things that, you know, they might not be super satisfied with. So just to ask, like, if you guys with the qual interviews were able to get anything that might have affected implementation outcomes that the FIM, the AIM, the IMM couldn't measure.
Yeah, no, that's a really good question, and that's a problem that we think we saw in our data as well. And this is sort of where that question about whether these concepts are appropriate for, you know, diverse settings, in the way that we're measuring them. Do they really, are they written in a way that encourages sort of variance in the response options, or is everybody sort of hitting the ceiling effect? And I think that's super important question to ask. When I look at the questions themselves, yeah, it's there's like a lot of social desirability that I think goes in there as well. With respect to our qual data, it was also pretty overwhelmingly positive, but there's a lot of qual data that we still need to analyze. For example, we have all of the meeting notes from all of the Play Collaborative meetings that need to be translated and analyzed. And that really, I think, could be a super rich data source to see, like, what are the problems that are needing to be solved? What's getting elevated? What's, you know, getting being taught cross-site? And it is just a matter of getting that information translated so that we can, you know, begin to work with those data. So, you know, with regard to like the interviews, how did you think of the intervention? You know, everybody's really positive, but there are other qual sources that we want to look at as well.
Any other questions? We are almost at the top of the hour, so this is the last one that we will take. Let me see if anyone else would like to jump in. If not, then I have a question for you, Candace, if I may, and it is a little bit broader. As you are kind of contemplating what you found in this study and you are advancing it, what is going to be the next big thing that you are planning to do based on what you learned here?
Yeah,
Not counting that funding is uncertain these days.
yeah. We're already doing a lot. We there is a lot of work underway already in response to these findings. For example, we're doing a lot of work to reinforce the gender transformative messaging in not only the intervention itself, but also to the EZUs, you know, because what we're dealing, we are measuring family violence, but we're also dealing with community level perceptions of violence and, you know, what's appropriate and what's not. And so when you're bringing in EZUs from the community to deliver the intervention, if they don't also have the beliefs that family reduction of violence is important or valid or what have you, then, you know, that's likely to affect the impact of the intervention. So we're doing a tremendous amount of gender transformative work with the EZUs, with the mentors. So, you know, looking at not only the training and supervision materials, but sort of how we engage them in an ongoing way to address that. We're also focusing a lot on the stimulating care and the play. We're creating a play repository that basically allows EZUs or whoever to find age-appropriate learning materials that can be made from materials in the home, you know, because these caregivers can't go out to a toy store and buy things. Like, that's not how this is working. They need to be able to create stimulating materials from materials in the home. And so we are building a repository that allows sort of dynamic engagement where you can check like the age level, the proficiency, you know, all of that then feeds into like, oh, here's some options for you to use. But it also allows people to input options as well. And then we are also working on looking at each module and building in behavioral reinforcement to strengthen intervention impact as well. So those things are ongoing, and we'll continue to do it. And we are still planning to scale to another district with the support of Grant Challenges Canada. So we're really lucky to have that support.
That's fantastic. Thank you so much. Thank you, Dr. Black. Thank you, everyone, for being here.